Okay, I'll just start out by saying I wanted to thank all of you guys, Jen, Margie, and Amena. We're at the home stretch here and a lot of excellent spectrum of work presented here, very motivational, um, setting goals for us to maximize the potential of our clinics. Really, the more we know, the more we realize how much we don't know. So I guess we'll start with a question.
I'll start. Question for Dr. Ream. I'm curious to know, sort of, you're collecting some really good information on the what, like what should we do, and maybe how things, learning about how things might change. But I'd like to know the why as well. I think that would be really important with any set of like guidelines or recommendations. And I feel like the pre-transplant testing, we have a pretty good why that we all understand, but once a transplant is done, for each recommendation that we're thinking of, why are we doing it and what do we do about the result? I think those will be important to add to that discussion.
I think that is really an excellent point. And so, clinically, what am I going to do with this MRI that shows a little bit more atrophy than it did last time? Really not much, because the child's already in PT and already doing everything that I can do. But yet I also know that we don't really know exactly for sure, like how long after transplant we may continue to see MRI changes. And so I have to, call Joanne and ask her if this is within the realm of what she would expect. And in fact, one of the comments that was placed in the survey, there was lots of opportunity for individual comments. Someone said something about atrophy, not progressing after 5 years. And I hadn't actually come across that before. And I so asked around and found some varying opinions. And so does atrophy that progresses after 5 years portend a worse outcome? I have no idea. And we won't know unless we collect that data. But if we collect the data, then is it research? And that's the circle we've been in the last couple of years that we've talked about this question.
Yeah, so I'm one biased because I think that every patient has information offered to us, and we don't know enough about this disease to close the door. It's not like treating strep throat where, penicillin usually takes care of it. And I really think if we're going to have new innovations, new therapies, we have to benchmark against whatever the progress has been to date. I think MRI is a very important test to follow, and whatever schedule we figure out, it can be less frequent the further out you get. But as patients are getting older, particularly those who are losing the ability to walk, one of the questions I have is it all peripheral neuropathy? Is part of it central? Is something happening to the brainstem? Now that we have longer term survivors, we're seeing autonomic dysfunction. Where is that coming from? Which nerve tracts are involved? So I think that, continuing to do the MRI is really important. I also know there are some kids, it's rare, but 5 to 10% develop hydrocephalus later on. And many of them do not have good ways of showing different symptomatology that leads you to that diagnosis. And without the MRI, you wouldn't know. So I think a certain level of surveillance on the central and the peripheral nervous system should continue minimally annually for as long as the patient survives, which fortunately is becoming longer and longer. And I think this distinction between research and clinical care is kind of a mistake in rare diseases where you don't know the whole story. And I also think it's a mistake when you have patients surviving longer than they used to, so you don't really know what's going to come or what to expect. I had one 20-year-old patient who started having withdrawing and non-communicating anymore, and we couldn't figure out, is it seizure, is it brain degeneration, whatever that is. It was a whole long sojourn for a year for that family before we figured out it actually was deep-seated seizures that responded to the appropriate medication, but it was a year. And how many 20-year-olds do we have with Krieger where we know what to expect or not to expect? So I know I'm rambling a little, but I think we should decide on a set of tests and a schedule that enable ongoing long-term follow-up of areas, organs, or parts of the nervous system that we may see changes in. And I don't think we know enough to just say, oh, it's cool, we did a transplant. Kind of, we don't have to follow anything anymore. I think that's wrong right now. And I come from the transplant background where everything we do is a combination of research and clinical care. And I don't think that's wrong. I think that's using what we can do to learn more and to make advances as we go on. And if it's financed through the healthcare systems, great. Because how else are we going to finance it? So I don't think that's something to avoid.
I have a lapel mic, so I can just talk when I want. I think I actually I'm in favor of surveillance too, so it sounds like I'm not, but I am. I do think we need to think a little bit about that distinction. I'm not necessarily because of any problem with doing research and clinical care at the same time, but more in the sense is that you probably have, pretty good database registry post-transplant that you're sort of recording all this information that you're collecting on a clinical basis. But if there's recommendations out there for whatever location that isn't tied in to any kind of ability to record or collect the data, then I don't know that that's as much helping to move forward, helping the field move forward if it's not like part of any data collection other than just kind of like rumors like, oh, that patient had this or this patient had that. So, then you have to think, I think we have to think a little bit more about cost benefit and what the patient's deductibles are and what the purpose of the testing and all that kind of thing.
I mean, that's why I think we need registries, and or a registry. We don't have enough patients to have too many registries for Krieger at least. But I also think that you can mine Epic now. I realize it's not as easy as it's supposed to be, but you really can pull data from the EMR if you have the right approach and can do that across the US. And I realize not everyone has Epic, so it gets complicated, but all of that is coming. And so I don't think that even somebody who's in a remote area and does 1 or 2 kids over 10 years should be excluded from providing and sharing that kind of data. Because we have to, because it's so rare.
Yeah, I agree. I think that probably in the setting of a
But
registry is the best, or registry database.
But I don't disagree that maybe you don't like visual evoked potential. I can tell you at Duke are useless. Okay. Especially they never, all we get back is kid didn't look at the light or kid did look, so no, I don't think we necessarily need to do that. And even auditory evoked responses after the initial diagnosis, I don't think are value added. But MRI, EMG, or nerve conduction, I believe EEG is valuable. I think those 3 would be sort of my menu of things to follow more frequently and on a consistent schedule basis. If you ask me after all the years of doing all the stuff I've done.
So to clarify, MRI, nerve conduction, and auditory evoked?
And
Or-
no, and EEG.
EEG. Okay.
Yeah. And then, the neurocognitive testing that's really important for the child's care. It's important for school placement. It's important for physical therapy and other supportive care, speech and occupational therapies. It depends where you live, what's required, but I think those are really very important for patient care and for maximizing the ability of the child's function. So I would add those in.
Actually, I have a question for Jennifer. You had mentioned using standardized EMR template, and is that within your institution or between institutions, and how do you use that and get buy-in?
So it's wishful thinking in the current state. So I'm trying to kind of figure out what are the key features that need to be in that, for diagnostic workup versus for individual disorders, and to sort of share that so people can have access to it. It sort of, I think, would at least if we're asking the same background questions and then the same longitudinal questions, and then even sending the same tests over and over and over again, until we know better, sort of the same as the post HSCT follow-up, kind of thinking, well, you should be getting, at some level. I don't know if we know all the answers to that yet, but hopefully my goal is to share it pretty much freely so that other people will do that. But so it's just what I've made for myself so far. I have the setup for what I do for if they come in without a diagnosis, and then I've started tailoring it to diagnoses. And happy to take input if others have it.
Any other questions? So I think that really, as we progress over time and we see that these patients post-transplant do survive, and obviously we can start integrating even more testing. Some of Amena's testing as well will be utilizable and useful. And then as these patients become adults too, then it becomes more important to have our adult colleagues not just aware that there's this unexplained pediatric world of leukodystrophies, but actually be as knowledgeable as they can. And I'm really grateful, and I think I could probably speak for most of the child neurologists here in the room, to see that an adult neurologist has really taken on this and really moving this forward, and hopefully be a beacon and an example for other sites to follow. Any other questions?
Question. Oh, go ahead.
Hello. Yes, elaborating a little bit more on the rationale for testing. One of the things that happens a lot too is sometimes, especially early in the stage in their life of the kiddos, they look okay. And the community, including the therapists and those who are caring for these children, lack of an understanding of the risk factors and the other associated comorbidities that these kiddos are at high risk for. So one of the things that has been helpful in having the community buy into helping these kiddos and being proactive about the neurorehabilitation is to actually have a picture of their brain that demonstrates what are the risks, and explaining them to the community so that they can see, these are the things that we need to watch for. Two of the patients that I follow did develop hydrocephalus, and one of them ended up with a shunt, and also a shunt failure, for which she required to be rehospitalized. So again, I think that having an image not only allows us to optimize and assess risk factors as neurologists, but also communicate the needs for those children to the community as a whole.
Definitely relevant for these patients, and I think that we're all, as mentioned earlier, we're all in this learning stage. So we're learning this as we go through it, and of course, the newer challenges will be, how will we educate this to the next generation of neurologists? Some of us, most of us, will have residents rotating and saying, okay, is this how to do it? And the answer is, this is how we're trying to do it now. Yeah, any other questions for any other panelists?
I do. Hey, sorry, Stephanie from Atlanta. I just have a comment about the testing and then a question. So I agree that in these rare things, you don't know what you don't know unless you look. So I think there does have to be a component of that, monitoring for these kids. But I think we do have to balance it with, the burden on the families, the discomfort for the kids, and also what are you going to do with those results? So my concern about doing, random EEGs in a kid that's not having anything concerning for seizure is, if you get abnormalities, then it's going to send you down this rabbit hole of additional testing. And what do I do with this? Does this kid need treated? So, I could clearly see it if the kid's having symptoms or some cognitive decline or something, but to just randomly do it, I don't know. I think results could send you in ways you don't want to go. And then EMGs, I don't know how many of y'all have had an EMG, but they are not a comfortable test. And I have a peripheral neuropathy, and when the techs don't get the results that they want, they keep hitting that button and it is not comfortable. So my concern is just discomfort for the kids with what you're going to do with that information. And I'm sure it's tech dependent and everything, but I'm just saying, you know, if we're going to expect they're going to have peripheral neuropathy, we're going to see a peripheral neuropathy, we're not going to do anything different with that information. Is it really worth putting the kid through that test? And I think Josh or Rob makes a good point that you have to balance it. Yeah, there's kids on Medicaid that the family's never going to incur a cost these tests, but there's other families that are going to feel that burden if we make recommendations for all this follow-up, but they're having to pay big copays and things like that. You know, we're putting a cost burden on those families too. And then my last thing is just, and this is a personal one, you know, following some of these things like Psychosine and GALC, you know, make recommendations to follow that. But I think we should make it clear that it is a little bit research-based, because otherwise thinking about me, honestly, if I get this elevated level, what do I do with it? But, you know, if there's some direction about like, okay, if you get this at this certain cutoff or something, you know, go in this direction or do this thing differently. But I mean, my fear about following these things is if I get a change in it, I don't know what to do with it. So anyway, those are just my comments. But my question was actually for you on the adults with leukodystrophies. The geneticist that we have at Emory has, the one who does adult genetics has always told me that for adult leukodystrophies that he's got a lower yield with the exome and the genome. So I was just kind of wondering kind of what your experience is with the yield of those testing.
So, yes, I've had one rejected because it said that your patient is not a child, stuff like that. And so, you know, we've actually been very successful in eventually getting testing done. We have to be really creative to figure out basically reviewing people's insurance ahead of time and knowing what the recent pattern has been for which types of testing has been approved. So, you know, sort of standard insurance and Medicare seem to be approving whole exome to some acceptable amount of copay for most people. And if not, then we find these sort of loopholes for whole genome, or sometimes it's panel if it ends up not being affordable. But there's so many different companies actually that we will sometimes transition to another one if we have some experience with the and confidence with the results. I have tried out some companies because I heard from people. I've actually had people referred to me who ended up sending testing through some of these companies, and I think Julia, I think, mentioned that some companies have genetic counseling associated with them to kind of see the type of results that we can get if we were unable to get it through our other sources. So, I mean, we're just constantly coming up with a new strategy, which is why I think right now there's not one way and it's not perfect, but so far we've mostly been able to get it.
Yeah, I just wanted to echo that's been our experience at Kennedy Krieger too. So like not only in the Leukodystrophy Center, but I work with, it was for a while Julie, but now another genetic counselor just in neurogenetics clinics, which is general neurogenetics. I do see a good amount of adults also with undiagnosed conditions there. And yeah, I mean, I think Jennifer hit all the high points, but you know, based on the insurance, we might have to do a stepwise approach. You know, lately it feels like that's been maybe starting with a leukodystrophy panel, but then, you know, being able to advance to exome sequencing. I don't know if Julie has any other thoughts, but fair enough.
I can repeat the question.
Yeah.
She also, Dr. Keller wanted to know the yield was. So if you take all your patients that come with undiagnosed white matter disorders and you do your battery of tests, including the metabolic tests and genome, what percent do you actually make a diagnosis? I think that's the question.
mean,
Is that correct?
It's a minority. I could certainly pull the data to see an exact percent, but it's definitely a minority that continue undiagnosed. And then as maybe it was you, others have talked about trying to, like, not closing the book, right? Like keeping people in the loop to sort of still do their neurologic evaluations, to send retesting, obviously, as more capabilities open up with insurance and testing in general. Like, so maybe somebody I saw 5 years ago and I did a panel and now I can do genome, now I can do exome, right? So we sort of keep them in the loop every several years, and being persistent like that has definitely increased the yield, but it's very few patients that remain undiagnosed that I've followed for 5 years or something like that.
I would add reanalysis also is very useful every several years.
Every 6 months I check in. I'm due for a 6-month check-in, but so far it's been about 25% with this combination of testing. I don't yet know if I have the right data to say like it's always with this type of testing or not. But I'll keep looking.
Yes, we had another question. Joanne.
I was just going to respond to the nerve conduction comment, which I know it's a bad test, but to be honest, when one of my Krieger kids comes back from testing and they say, oh, it was easy this time, I know we're in trouble. Okay, because it means they lost the sensory input and it doesn't hurt anymore. And it's a bad thing, right? Yeah. Yeah. Yeah, no, I know, but yeah, I mean, I get it, but for most of our patients, they want to know if the nerve conduction has progressed. And it does affect what the physical therapists do. And I mean, that's a whole nother battle fighting to continue PT. I mean, insurance to pay for PT, not the PT itself. But, I don't know. I think it's a package. Yeah.
Question for Dr. Smith-Fine in terms of the remote assessments. I think maybe it was Dr. Keller who mentioned one of their clinical trials that she's a part of, that they still do like the time walk as part of their 4-day assessment. Do you see any movement towards these clinical trials for leukodystrophies really meaningfully incorporating more of the wearables? Just because I think that these kids, are often, I just don't know how fully reliable it is. They're coming from out of town and maybe going to the museum the day before because they're in like a new city, and then like they're tired and didn't sleep well in a hotel, and then we're asking something that's going to be really important for the outcome. So I'm just curious if we're moving towards more of like a longitudinal wearable for these leukodystrophy trials.
Yeah, great question. And there is more openness to that. I think so. You sort of hit the nail on the head in terms of thinking about what's the testing environment for the patient, and that's really important. And obviously, when they're like, they have like you said, they've traveled, they're in a new city, they've probably had a super busy day. Who knows at what point in the day they're doing the walking assessments, and then you get one shot. Right. And it's even hard to do reliability analysis, like for that patient's trajectory or, et cetera, if you don't have like a day 1 to day 2. So the nice thing, again, about the opals is like we do, you can control, like if they had a bad day or they're sick or, et cetera, like you can reschedule. It does allow for us to pretty easily just say, we'll keep the equipment, for like a subset of patients, we said, we'll keep the equipment and we'll do testing again the next day. We try to keep that consistent longitudinally for the natural history. Have some, there's some unfortunate news that there was, I think they were maybe 3 years in. There was a company, I think it was Swan Bio, was doing adult ALD assessments with the wearables every 6 months. Maybe I think it was actually every 6 months. They were doing it remotely. I was like really excited to see the outcome of that. And then the study is ended. So I think that some of that data is going to be published. But there was already clearly some openness of sponsored trials moving in that direction to take advantage of the wearables. I think still some of the tests are the same, right? So you're still getting, there's still overlap, whether you get in clinic or with the wearables, It's going to be a self-selected walk pace or a fast as possible walk pace. Clearly it's much easier to just get with a 6-minute walk test or something in clinic, you're getting the meters walked. What you miss is like all of the richness of those other variables that are pulled out with the opals, where maybe it's not going to be the meters walked. It might be some other aspect of the walking that's the most sensitive measure. So yeah, we'll just keep spreading the word, but it does seem like it's picking up, and then there are even certainly there's lots of other devices as well. And there's like actigraphy that's looking a little bit more at daily activity, step counts. Like there's lots of creative ways, especially if you talk about raw data analysis and machine learning, where the potential of this is just sort of barely tapped into. So I think it's hopefully moving in that direction.
And just to piggyback on that, do you see the wearables becoming more broadly used, or kind of a utilization for them in clinical setting outside of, we talked about it more in clinical trials in this setting today, but I'm curious what your thoughts are for like a clinical based use for wearables.
Yeah, well, that's actually, so like ironically, that's kind of where it started. And so the company who makes the opals, like Parkinson's is APDM, and the PD is Parkinson's disease. And so it was used heavily in Parkinson's disease research, but also in clinics. And actually the first time I ever saw the opals was in the Hopkins, I think it was in it was at movement disorders clinic. And I was like, oh, you have opals, but they weren't using them for research. I think they were just trying to establish patients' baseline. And I've had, long-term natural history patients that want me to connect with their local PT to talk about, what are we getting with the sensors for this person? Like, what can we tell about with their 6-minute walk test? And then they're going through that with their PTs also. So there's an opportunity to exchange that information and try to like help people's therapy plans also. So certainly.
Right. Anything else? Any other questions?
I have a question for Dr. Fine. So which walking test should I do in clinic?
Whatever test the patient can do. Yeah, I mean, I'm a little biased towards the 2-minute walking test because really though, it's a lot, it's a long day. People are exhausted. I don't have a great sense of what the effort is. And sometimes it seems, we have spotters, like you have to have multiple people there to make sure it's safe. I've seen their ability, again, we're looking out a few years, right? So people may lose the ability to do a 6-minute walk, but they can still do a self-selected walk for a brief period of time. I mean, you could probably get great walking data in 30 seconds, with wearables. We just need sort of enough gait cycles up and back. And then it's sort of yeah. So that's essentially the idea, is whatever they can do and whatever you think they'll be able to continue to do for the longest amount of time possible. Does that make sense? Yeah.
What kind of experience have you had with utilizing some of the wearables and checking up on them through telemedicine?
So do you mean in terms of, like like visit compliance or? Yeah. So, so that was a bit of a, it was it was a little risky when we started all this, but we've been doing it for LBSL, this more of a mostly pediatric onset leukodystrophy since I guess 2018 regularly at home. And we've never lost a kit. Fingers crossed, they've always been brought back. Nobody's ever held on to a kit for longer than like maybe a week was the longest time, and we were starting to get a little bit nervous. And then hopefully I can remember the numbers because I just looked at this for another purpose. But I think 75% of our LBSL patients, because this is the longest study, 75% of them did the testing consistently for at least 4 years. And then there were not only, I think it was 90%. Oh, no. So let's see. Yeah, 75% for at least 4 years. That's what I can say in terms of consistency.